All right, so we'll start. Hi, thanks for the invite. So I was asked to speak about PEDS topics. For those who don't know me, I'm Philippe Ouelette. I work at the MGH a little bit and as a TTL and Emerge, but I also work in Saint-Jean-sur-Richelieu, which is a big community center, and we see kids. So that's the reason why they asked me to speak about PEDS topic. So I hope you're in a good mood. This is not a light talk. Since I'm sharing a part of my screen, I won't be able to see written questions. So please open your mic if you want to answer questions I'll ask, or questions you have can interrupt me during. But I'll keep some time at the end for questions, oral or in the chat. So don't worry if you don't have time or don't want to speak up. We can speak at the end. Okay. So my objectives for us today are to recognize a very sick kid, how to plan for the worst in those situations, and to develop an approach to PEDS resus, trauma, and death. So we'll do that with real cases and what I learned from them. So it's not a traditional talk in the sense that I won't be going through in-depth PEDS Rosens or otherwise a matter, but I'll share what I learned from these cases, and hopefully there's one or two things that will be useful for you. So the first case is on a Friday night. Obviously, a Friday evening is very busy. It's November, and you're covering resus, and nurse calls you for a new patient that's sitting in resus. So you always got to evaluate if it's a, I'll finish my note, then I'll come kind of urgent, or if it's a, I'll finish with my patient, or I'll drop my LP and run kind of scenario. And in that case, it was the third one. So it's an 8-month-old female that's healthy prior, vaccinated with no atopic history for her or her family. And she had URI symptoms for the last 4 days. She's breathing fast, she had low-grade fever, and she's not feeding since this morning. So she has vital signs like this. So a pulse that's a bit elevated at 180, a BP that's okay. She's breathing at 75, and she has a SAT of 89 on 2 liters nasal prongs that were put on just prior to her arrival, and she has a rectal temp of 38.5. The kid is quiet, she's not crying, and there's audible wheezing that you hear when you get in the resus bay. She has nasal flaring, head bobbing, and generalized retractions. She's very pale, and she has a cap refill of 3 seconds. She looks a bit like this. She looks sick. Okay, so just a word about Gestalt. I know we talked about this in the past, but if you say when you see a sick kid, you'll know. That's probably because you might be unaware that just knowing is actually an internalized compendium of many discrete variables that you assessed. So for junior learners, or for all of you in a teaching position, it might be useful to deconstruct what enters the sick child assessment. And I remember when I was studying Rosens, I remember this triangle right there. And I was thinking it's kind of silly. Maybe because by that point, I had seen and recognized enough sick kids that I did not have to think, well, what's the appearance of this kid? How's this work of breathing? And what's the circulation to skin? But just an example of how it's important to think about that. Because when we learn, we're in stages. There's different stages before becoming an expert that you know about. You start by being unaware that you don't know something. Then you're aware that you don't know, which is good. Then you're aware that you know. And finally, when it's been too long that you know, you forget and you think things are easy, when in fact they're in a slowly acquired bunch of data points. I put it in yellow there because sometimes being unaware that things might be complex to others around you might be detrimental to teaching or to communication in a crisis. So one important thing to remember about that is that as a person, you're in multiple stages at the same time, depending on the competence or the skill that we're talking about. So back to our patients. So I'd like you guys to tell me, what are your first management steps other than those ones? If someone wants to step up. And if you're writing in the chat, I'm not seeing it. Okay, so they're really blank. No one? Okay, last chance. Don't want to manage this patient.
So go ahead, Mariam.
Sorry. So I mean, patient need to be on monitor for sure, and we need to start on oxygen based on the saturation. But for now, the way that she looks, actually, she needs. I mean, like she's sick looking, like she's a toxic looking child. So we need to get all the bloods, all the cultures, start some antibiotic for now, and get an LP, and I mean every septic management for the first step.
All right. So you have a pretty good history, and I agree with this. And you set up to do everything. You suction the kid because she's full of secretions, and you order some fluid resuscitation, and you order some labs, septic workup, and those labs here with a VBG or a cap blood gas if you're not able to get a VBG from the kid. Anyone wants to try bronchodilators?
If there is history of atopia or asthma, I would, but here the thought process, it's bronchiolitis. Bronchodilators initially are not the standard of treatment. Sure, if deep suctioning failed, or if I do deep suctioning and I don't get much and I do an x-ray and there is no consolidation, it's worth a try. So I would not do it initially. Maybe I would do it later. I have more priorities to address now, the volume status and the respiratory distress.
So I'm happy you said that. So, you know, in those cases, bronchodilators are usually ordered, and there's usually someone to tell you that there's no evidence for it. I totally agree. This is a very sick patient, though. So if it's not delaying your management, I think there's a little harm in trying it. But I agree with your points that you don't want to delay other measures because you do think that it's bronchiolitis, but you do run through a differential diagnosis. You're pretty set on the first one, but you have to think about the other ones. So you ordered a chest x-ray, like you said, because they're sick enough that you want to exclude reversible causes, get a good history to exclude foreign body, look for the signs that might point to anaphylaxis, CHF, GERD, or those weird things there. And as you expected, your chest x-ray doesn't look too specific. So hyperinflation may be increased peribrachial thickening that you see, and you don't see a big focal lung consolidation. So other questions for you guys. Can you name admission criteria that this patient has? Just out of your head.
The oxygen requirement not responding to nasal prongs.
All right. Do you have a specific number?
I always said 90.
90 or 92.
88, 90.
All right. So there's the how fast she breathes, right? So we usually say 70 as an admission criteria. O2 is 90. Let's say frequent suctioning needing for stability, which is the case for our patient too. And dehydration or history of poor fluid intake, which is also the case. So she has 4 major admission criteria. Others are these, but your concern is not that she needs admission to the hospital, but she might need admission to a PICU, which you don't have in your hospital. So you've already started the basic treatments, and we discussed this, and I'm sure you guys have been hammered about this. I just want to reinstate the recommended treatments for bronchiolitis, which is O2 and hydration, which is getting. Even try the other things, which are equivocal, and you might even try a couple of things that are not directly recommended because this is very sick patients. And as I said, and it's and sometimes you do a little bit more if there's no harm to cover a little bit wider. So you tried a couple of things and there's no response. In fact, you're under the impression that she starts to breathe a little bit slower, but she's still wheezing and she is not perking up in terms of her cap refill, and her SAT is now 91 on 100% non-rebreather. So the VBG comes back. It's very worrisome because unless this kid's a 20-pack-year smoker, that PCO2 is high, 100% hypercapnic resp failure, and she is failing. But you knew that from looking at her, right? You didn't need a blood gas to tell you that she was doing less and less well. It's because of her respiratory effort, the fact that she was tiring. So what now is your next step?
You can try high flow nasal cannula.
All right. Any other ideas? Let's say 2 next steps.
Non-invasive ventilation.
Right. So you're right. So your next step is to support the ventilation. So we mentioned high flow nasal cannula, but it could be CPAP. It can also be endotracheal intubation, but this is a gradation, like a spectrum. So you might start with the high flow nasal cannula and move from there. What else? What do you need next? What do you need to do next?
Call RCU, PICU, or if I don't have PICU in my institute, call for transfer.
All right, very good. So you guys nailed it. It's a good thing that you guys said exactly what you needed to say according to my icons. So it's not messing up my presentation. So yeah, so you want to transfer this patient, right? We want to do this as early as possible, as safely as possible. So in this case, it involves having an MD on board with the nurse and an IT. So just a little bit of a word about transferring patients, because I know in residence it's not something that you're used to. It's more something that you're receiving patients, but it's something that you'll probably have to face wherever you work in the future. So it's very tricky to transfer unstable patients because by definition they're unstable, and you can't just keep them until they're unstable because that's the reason you're transferring them. Especially kids, because they become less well really rapidly. So transfers are high risk moments where your goal is to stabilize as much as you can before the transfer, to continue optimal care during transport. So it's not a pause in your care, and to minimize potential adverse events. Any transport monitoring is suboptimal due to movement, space, the stuff that you have that you're not familiar with, or sometimes you're missing equipment. Agitation of the patient can be detrimental to them. And in a kid especially, it's very scary to be in an ambulance with strangers when you're sick as a kid. It's an unknown and scary environment for the kid. So what you need to do is at least have weight adjusted material ready prior to transport. It's something that you need to work on in advance. Monitoring that's appropriate. So double, triple taping everything. So especially if you have tubes, the mask, anything you have for monitoring. We always say that you need IVs, but the number of IVs is always a problem, especially in kids. You don't want to poke them too much, but in a very sick kid like this, you always need an IV, plus another one in case that one fails, because the last thing you want is an IV that failed in the middle of Bronchiolitis that you need to put back. And in kids, you have to think about comfort. So you think to comfort them, whereas it'd be like a doo-doo or whatever, Polish, and the parent that accompanies them, and the other parent, the address or where you're going, so the other parents can join as fast as possible. So all of this could be worked up in advance with checklists. You need good documentation, and you need team training. And we can talk about inter-hospital transfers another time. That's it. That's pretty much it for the first case. So the conclusion of my case was actually very interesting. So we transferred that patient with an urgent ambulance on CPAP because they failed the high flow nasal cannula. And everything went well until we got to the parking lot of the referring hospital, the transferring hospital, where the kid started to have a distress episode, like a respiratory distress. It was about 2 minutes. We were in the parking lot. So we actually called to let them know that the kid was not doing as well. And we asked them to meet us at the door of the ambulance with a CPAP, because we had to disconnect the kid to transfer to the resus room, and they didn't have one. So they said, just come in. So that was a very high stake situation where the kid was in distress, and we had to disconnect them from the CPAP to actually bring them in the resus bay. So we did. And there was actually no CPAP or high flow nasal cannula in the ED. And ICU was not ready for the admission. And the kid ended up being intubated, not clear if it was progression of the disease or a delay in the reinstatement of ventilatory support. So my take homes for this case is that bronchiolitis, as you know, needs to be treated with aggressive support care and good monitoring. You need to exclude other differential diagnosis in sick kids. It's something you do from the get-go, as you guys said very well. I just want to say that I think it's okay to try bronchodilators in sick bronchiolitis. I think we get hammered with the fact that it doesn't work. And I think we don't want to give bronchodilators to bronchiolitis kids. I think it's mostly for the kids that you see every day with bronchiolitis. And a kid like this, it's not something that I care if it doesn't delay the life-saving measures or other more important things. High flow nasal cannula, CPAP, should be available in the ED, in each ED, I think. And in terms of transfer, it's something that you need to plan from the get-go, so it's as early as possible and as safe as possible. All right, I'll take questions if you have any for this case.
Hey, Phil. I was wondering if when you called to organize the transfer, was there pressure from the team there at all to intubate before transfer, or were you close enough? Like, I think probably Saint-Jean, you're like 30 minutes away from the MCH as the crow flies, as they say. But were they at all concerned that the scenario where she might deteriorate and require intubation would happen the way it did? It sounded like she was fine on CPAP, and it was really like a bit of the delay that caused the worsening. But did they at all?
No, so they didn't insist on that. So the way it works at our shop is it's not always the doc that takes care of the patient that transfers the patient, depending on who has the resus and who has other patients to work on. So I wasn't involved from the get-go for that patient. So when I was called for transfer, I saw the kid who was actually pretty well. She had a worrisome VBG and work of breathing when she came in, and she had nasal cannula put on. And it helped, and then didn't help, and the gas and the VBG became worse, and then that's when they called to organize transfer. So then they advised to put on CPAP. The CPAP helped, the VBG normalized, and the kid was doing pretty well. So at that point, that's when I got involved, and we agreed to keep the same treatment and to transfer like that. So I've yet to encounter a situation where the children's tell us to intubate. To be honest, the ones I've seen, we've either dealt with that prior to calling them, or they were stable enough. As you said, it's a really short distance, so to delay the transfer if you're not completely sure they need it, sometimes it's a thing you need to think about very strongly. Of course,
especially since she responded, like you said, to the CPAP, you got like a gas that looked better. Okay, cool.
Right, for sure. If she deteriorated, I think it's safer to do that prior to leaving. But in that specific case, we thought she'd benefit more from definitive care. All right.